For overview of non-invasive ventilation. So, keeping the same pace and the same similar topic of less invasive or non-invasive. So, what is going on in surfactant delivery approaches? So, this is the topic of my talk, that less invasive surfactant delivery. So, I will overview it. I'll go through some recent randomized controlled trials, Cpap and NIPPV with less invasive surfactant, how easy its implementation, and some long-term outcome. In generalization, if you can see that limiting invasive ventilation within is desirable. Of course, we don't need, as in previous talk, you heard about the adverse effect of invasive ventilation. So even when appropriately used, the invasive ventilation is not a good option unless and until we have in a dire situation. Imagine if we use inappropriately, they become unnecessary evil. Similarly, the non-invasive ventilation also has its own effects and effects. So the Cpap, for example, nasal trauma, pneumothoraces, NIPPV related to the bowel perforations, high flow nasal cannula infections, perforated eardrums, low flow nasal cannula, mucosal trauma, and so on and so forth. So we have to think something more less invasive than this. So in Cochrane review 2007, I try to go always in a chronological order. So let's say 2007, almost 13 years ago, this is the Cochrane review. And they publish about the early surfactant administration with a brief ventilation versus selective surfactant and continued mechanical ventilation. So early surfactant with extubation to Cpap is better than invasive ventilation. We all know that. And surfactant by transient intubation using a low treatment, which is we called INSURE technique, low treatment threshold is preferable. And there are many trials on that, which showed that the Cpap alone is having a good result. The death of BPD, as is in the COIN trial, support trial, WAN Cpap, and WAN intubation, surfactant, and extubation trial, all are going in favor of non-invasive ventilation. But there are some complications also, especially if you see the COIN trial, the 9% having the pneumothorax. Now, the intubation, ventilation versus Cpap, we can easily say that the Cpap is better when the outcome is the risk of death or BPD. But what happened that if you don't give the surfactant or give the surfactant, so Cpap from birth without administration of the surfactant, and the lot of those trials show lot of failures of the Cpap. So as I said before, this is again from the Dr. Peter Davis group, and they published in 2016, Incidence and Outcome of Cpap Failure in Preterm Infants. And as you can see, the failure of the Cpap in 25 to 28 weeks is about 43%, and 29 to 32 weeks is about 21%. The Cpap failure was associated with a higher rate of pneumothorax, death, and bronchopulmonary dysplasia. So yes, it shows that Cpap is beneficial, but when it fails, it is really morbid condition, and we have to deal with this very sick baby. So the incidence of death or BPD was increased in the failure group of the Cpap. The surfactant replacement therapy, we all know prophylactic surfactant initially decrease the neonatal mortality, pneumothorax, and the PIE, and if you combine the BPD and the death. But initial, should we use prophylactic? Should we use early rescue or rescue? This is the question. So very early surfactant without mandatory ventilation in premature infant, treatment with early Cpap. This is a randomized controlled trial published in 2009, and quite a decent number, 279 infant, 27 to 31 week gestation with 15 to 60 minutes of age, and evidence of respiratory distress and treatment with oxygen in the delivery room. So they're randomized to intubation, surfactant, and extubation to Cpap or Cpap alone group. Now, if you can see here that need for mechanical ventilation is clearly less in prophylactic surfactant, which is less than 0.05 probability. So it is statistically significant. Also, the air leak is statistically significant in the prophylactic surfactant group. But the surfactant more than 1 hour is the same, and chronic lung disease did not show any difference. So the intubation, ventilation versus insure technique, of course, insure technique show a little bit better outcome on death or BPD. If you combine insure versus alone the Cpap, many of the studies show nothing, no difference, but except the study which I showed you, which is called the ROHAS study. So if you combine all these things and see the risk of death or BPD at 36 weeks, the CurePap, the ROHAS, and the VON study, the difference is not there as it crosses the confidence interval of 1. So similar finding of death and air leak. But I borrowed this slide from the Professor Ramanathan. He mentioned that if you use early insure plus nasal CPAP versus NIPPV, so you do the insure and put the baby on NIPPV in less than 30 weeks, they found a better result as compared to the CPAP with the NIPPV. So you give the insure technique, give the surfactant, and put the baby on NIPPV, then the mechanical ventilation need at 7 days is decreased, extubation failure is decreased, physiological BPD is also decreased, oxygen at 36 weeks as post-menstrual age is also decreased. Conclusion is for this initial summary is the non-invasive support, or is at least as effective as invasive support, ensure is not consistently superior to the CPAP alone. Long-term outcomes are still needed. So why less invasive surfactant delivery? So why it is come into the mind that if we can do deliver the surfactant more less invasive as insure, it means without tube, because there are infants failing insure are often intubated and mechanically ventilated. So same problem happening with the CPAP failure. So this is the data showed by Professor Ramanathan from Western California or the California, and it shows that the severe radiological grade and they are failing after the insure. So the hypothesis developed, would even less invasive surfactant administration to a spontaneously breathing neonate improve outcomes further? And it give many ideas. So give a pharyngeal administration via the laryngeal mask airway of surfactant, aerosolized surfactant, and thin catheter administration. I will focus on the thin catheter administration for this part of my talk. First of all, what is the difference between insure versus all these terms you use? LISA, which is less invasive surfactant administration, minimal invasive surfactant treatment, and less invasive surfactant treatment. So insure, we have to have laryngoscopy, same with the LISA. Need for PPV, yes, for insure technique, but LISA and list or all those less invasive required relies on spontaneous breathing. Endotracheal tube needed for that. For less invasive, we are using the thin catheters. I will come back on that. Is secure airway and must be careful with the LISA. Vocal cord position remains abducted because baby is intubated. Vocal cords can be adducted. in the less invasive. Sedative, often used when we are using insure technique, less often used when we are doing less invasive method. More than 30 weeks, more tolerate the procedure of insure, and extremely low gestational age babies can also tolerate the less invasive technique. The surfactant kinetics, the lung association of surfactant is less, and the dynamic compliance is low, but in less invasive method, better distribution and improve dynamic compliance. There are many techniques are going on, Cologne method, Sonshore, Take Care method, Hobart, and they are using different types of laryngoscope with Magel forceps, laryngoscope with no forceps, laryngoscope with no forceps, and so on and so forth. So whatever it is, you master it, you can do accordingly. There is a survey happened in Europe and published in 2018, because there is a catheter which is called Lisa catheter, developed by the same company which is procuring the CuroSurf. And they found it out that the most of those neonatologists from Austria, Belgium, Poland, Spain, and UK prefer to use this thin catheter as compared to the angiocath, which is in the red, and no difference, which is yellow, very few. So most of them are using the catheter, and they found it out it is easy to use as compared to the other catheters. Now come to the evidence. So what are the evidence right now? Initially, we have some non-randomized controlled trials started by Dr. Angela Krebs, who was the pioneer of this method from Germany. And there are many trials, but most of them are not that big, 29 babies, 150, then 319 babies, and then 164 babies. And they found some improvement, that lower prevalence of mechanical ventilation, less BPD as compared to the standard of care. So there are many non-randomized controlled trials through period of up till 2015. Then we have published randomized controlled trials for AMV trial, which is avoidance of mechanical ventilation, Take Care trial, NINSAP trial from German group, Mohammad Zadeh from Iran, and the Bao from China. And the primary outcome, need for any mechanical ventilation or being not ventilated but having PCO2 more than 65 mmHg, need for early mechanical ventilation, survival without BPD, need for mechanical ventilation, and duration of oxygen therapy. So randomized controlled trials of thin catheter administration, these are some outcomes. So in 2015, from China, they found there is no difference in the mechanical ventilation in the first 72 hours BPD pneumothorax. So they couldn't find any difference. From Turkey, there is a trial in 2013, and they found it out rate of mechanical ventilation in the first 72 hours of life and BPD lower in the thin catheter administration. Similarly, from the Iran, the 3-center trial said that the mortality lower in the thin catheter administration group. Another trial from Iran showing the similar kind of results. But the major trial from 2011 to 2017, which has a lot of the babies and the multi-center trials, one from the Germany with 12 hospitals, is called Avoiding of Mechanical Ventilation. And they clearly found it out that lower rate of intubation with the thin catheter group intubation as compared to the intubation group, no difference in mortality, pneumothorax, or BPD. Angela Krebs trial, which is an NSAP called non-intubated surfactant application, is a reduction in absolute risk of survival without BPD and pneumothorax in the TCA group compared with the selective intubation. And Oliver from Canada, the 3-hospital trial, also found it out the absolute risk reduction in the need for mechanical ventilation on pneumothorax. There is another trial published in 2016, and it is interesting. So that's why I put it in my talk. It is published in JAMA in 2016 by Isayama and his group. He compared association of non-invasive ventilation strategies with mortality and BPD among preterm infants. So first he showed, compared with the mechanical ventilation, Lisa had a lower rate of primary outcome. So the odd ratio is 0.49 and BPD is 0.53. And as you can see, the confidence interval not crossing the line of 1. And compared with the Cpap also, Lisa had a lower rate of primary outcome. So he compared the Lisa technique with the mechanical ventilation and both with the Cpap. And interestingly, he put it as a ranking probability of the strategies. So which one is the best one is the one, and so on and so forth. So as you can see in the first outcome, which is death and or chronic lung disease, he thinks Lisa is ranking median is number one. So it means that there's a very high probability with the Lisa to have a very few deaths or the chronic lung disease. Similarly, alone the bronchopulmonary dysplasia, the Lisa acquire the number one position as compared to the other. The BPD with the second is the Ensure, third is the NIPV, and nasal CPAP alone is the fourth. So these are the ranking strategies, just get my attention to that. So overall, in 2016, again, the Lisa versus Ensure is published, and they found it out BPD all patient, BPD in survivor, death or BPD early nasal CPAP, any mechanical ventilation and any mechanical ventilation reported all goes in favor of Lisa. The other morbidities, there is no difference in PDA, NEC, severe IVH, death or other morbidities. The only thing is the last one, which is the surfactant reflex. Of course, this is the technique you have to learn and to master it, to go it slowly. I will come into in a minute to that. Another one from the Alberta, Canada, the similar type of the result showed, it's published in 2017 in Archive Disease of Childhood, and they found it out that or BPD at 36 weeks is better in Lisa, BPD at 36 weeks in survivor less in Lisa, mechanical ventilation and mechanical ventilation less than 72 hours or any time is less than in Lisa technique. And of course, the surfactant reflex is there. There are some risk factors. Again, I recently borrowed these slides from Dr. Ramanathan. He published in Fetal and Neonatal Medicine in April 2009. There are some failures of this less invasive techniques. And it has some variables that if you fulfill those criteria, then the chances of success is high. So for example, if a surfactant dose less than 200 milligram, the chances of failure of this technique is high. If no antenatal steroid, then the chances of failure is high. If there is infection and severe infection, although it's not statistically significant, but still the chances of failure is high. Oxygen before miss is no difference. IVH grade 2, if it is already there, then the chances of failure is high and is statistically significant. So I think this study gave us some idea that which baby which we select for this technique. So the baby who just came and deliver or pop out without any antenatal steroid, don't have proper antenatal care, I think this is not the candidate for the Lisa technique. The second question arises that at what FiO2 we should give surfactant, at 30% or 40% or 0.3 or 0.4. So there are two variables in this, a modeling cohort and validation cohort. And they find it out that the maximum FiO2, 30% and above, it is significant, and it shows that in the second hour, if you have a 30% or more FiO2, the chances of your CPAP alone failure is very high. And also you can add up with the radiographic severe RDS predicted. So this is very good, give you a very good idea that this candidate can be a good candidate for the LISA technique. Similarly, last year, very comprehensive guidelines published, and Dr. Ola Sagastad, which is also our speaker tomorrow, also the part of this guidelines, and what they recommend how to treat the RDS. The CPAP with early rescue surfactant is considered optimal management for babies with RDS. So A1, which is a very high level of evidence. Babies with RDS should be given rescue surfactant early in the course of the disease, and it is again showing the 30% or above, you should give the surfactant, and it is evidence level of B2, which is moderate. And LISA is the preferred method to give the surfactant, and again, the evidence is B2, which is moderately good evidence. Now, we have the evidence that LISA has some effect and some better effect. Then the question arises that, okay, you are doing with some catheters, its implementation is difficult or not. So this is a study published from Poland, experience of a mid-sized country, the implementation of less invasive surfactant administration, and it is just published in July 2020. What they did, they take two groups, one the resident, which is early in their career, and the one is specialist, which are the mid in their career. And most of them, they said it is easy and it is easy to learn and it is not difficult to implement. Also in this graph, they showed in different quarters when they get more training and more education, the 76% of those are saying this is easy technique to implement. So they conclude that the LISA procedure does not appear to be technically difficult to master. Training combining theory with practical exercise is an efficient implementation strategy. Similar study just published in April to 2020 in Scotland. They put in level 3 unit, and they said that we have successfully introduced the LISA technique into our department, and 72% of the patients in our series did intubation and ventilation. So what is going on right now around the world who are using these techniques? Mostly in the European countries, as you can see that in this graph, it is starting almost the 2000 and then 2010 and 12 and then 14, there's a steep up in that. So there's an online questionnaire, 37 European countries, 51 response rate, 52% using LISA, 41% standard procedure for surfactant administration. Also in the UK, the similar result, they are using a lot, and LISA was used regularly in 35, which is 19% units in the UK, and most of them giving surfactant at 30% oxygen. And they are using in a very low, very small babies also. The North America, or the American actually, because this is the study done by one of my fellows, Dr. Shahana, and she published in 2019 in Journal of Perinatology, and there is still some doubts in the USA to use this technique, and they need more evidence. So either they are using as a research purposes, or unlike several regions of Europe, LISA is not widely used as in the US. So still there are some questioning about that in the North America. But this technique also has some troubles. And what are the troubleshooters? So if the baby has bradycardia desaturation during technique, many of them using atropine. But when we were using it, we are not giving anything, and we don't have faced this problem. Apnea, the caffeine we use very early, right away after the birth. So this is one of the reason we didn't get that problem. LISA, if it is failed on first time, they start using sedation. Depth of insertion depth is from the Melbourne. They said is 1.5 centimeter for less than 27 weeks and 2 centimeter for all other babies is quite enough. If dislodge the catheter, you can check it with the easy cap carbon dioxide detector. If it is coughing and gagging, then slow administration needed. So for the reflex, there are many things, many different units are doing, but to give it in a very slow manner, over 2 to 3 minutes, it will solve this problem. Improving LISA success, and we always doing that whenever we do the LISA, we put the baby of NIPBV as compared to the Cpap. Now the outcome, which is published only by the one center so far, but there are many other studies going on. It is from the University of Vienna. Their group is 23, 27 week, the LISA cohort, and quite a big number of LISA cohort, 557. And they found it out that 26% is normal, 22.8% is a mild impairment, moderate impairment is 13.1, and the severe is 4.7. But the death is 18.3% as compared to the 41.1% in the control. So it's a very encouraging result. Similar results at the 5 years LISA group, they use 23 weeks to up to 27 weeks. The total number is 236. And they've mentioned it's 76% at 5 years when they do the cognition scores by using these two scores, KBC and KBC2, and they found that 76% is normal, only 14% get mild, and 5% moderate and severe in each group. So they conclude that not only increased survival, but also increased survival with favorable neurodevelopmental outcome after LISA in the Vienna. This one is just published in April 2020, the less invasive surfactant administration best practice and unanswered question. They just put the commentary on that maintenance of spontaneous breathing with support by the LISA technique holds big promise. Patient comfort and lower complication rates are strong. Arguments, open question include exact indication, as we just said, that which baby is fit for this technique, the issue of analgesia and sedation during the procedure, and studies on the long-term outcome is still going on. So just to conclude my talk, again, this is the slide from Professor Ramanathan, the surfactant therapy, past, present, and future. In 1980, we don't have the animal surfactant. We have only synthetic, which is Exosurf, which has not that great efficacy, prophylaxis versus early, the surfactant treatment in intubated patient, and at that time, we are mostly intubating all the patients. Then in 1990 to 2020s, we start with the non-invasive, then insure technique, then LISA technique, and we come to know that no prophylactic surfactant treatment with increasing antenatal steroid use. Future can be the LISA plus NIPPV or intubation, rescue surfactant and extubation, or the non-invasive surfactant treatment, which is the inhaled surfactant or nebulization. 4 major interventions to manage RDS in very low birth and extremely low birth weight baby: antenatal steroid, nasal Cpap, or NIPPV plus early rescue surfactant by the LISA plus caffeine, early caffeine as much as possible. So to summary, the increased using of Cpap as initial respiratory therapy of preterm infant with the RDS raised the question whether surfactant application during Cpap is possible. The answer is yes, it is possible and it is effective. The number of studies demonstrate the feasibility of surfactant application during Cpap or NIPPV via thin endotracheal catheter lead to the hypothesis that the method may be beneficial, and as I showed you, there are many randomized controlled trials show its benefit. RCTs demonstrates an effect on the need of for mechanical ventilation. Yes, it showed that it reduced the use of mechanical ventilations. And reduction of neonatal complications seems possible. Again, the answer is yes. Positive effect on neurological and respiratory outcome, as much as we know from the Vienna group, it is a positive effect that there is no neurodevelopmental delay or derangement in the LISA group, but still the large cohort is needed, and the studies are studies are going on. With that, I will finish my talk, and then we'll go through the question answer session.